I just want to give a quick introduction as to who you are. Of course, for our guest, this is Dr. Lipkis. He is joining us today for a Q&A on shared decision-making. Dr. Lipkis is a well-accomplished physician based in the Chicago area. He is a past columnist on the Atlantic Online, the Chicago Sun-Times, as well as the Daily Herald. He's also a very well-seasoned author and has published Live Longer and Healthier, Healthy Mind, Healthy Body, Hacking into Happiness, and The Popcorn Diet, to name a few. So Dr. Lipkis, again, it's a pleasure to have you here today. The premise of our conversation today will be focusing, of course, on shared decision-making within a clinical context. And this is, of course, a very, how do I say, a topic that's been published on time and time again within academic literature. And it's something that we see as a need in healthcare, but the adoption just isn't always there. So for the purpose of our guest today, what we've done is summarized a few questions just as a general Q&A to kind of get your insight into shared decision-making, how it impacts us, and where we're going in the future. So to set the scene, I'll ask you a very introductory question, of course. And this is just to give our audience and our viewers a sense of what shared decision-making is. Of course, we have audience members that may not necessarily be from a clinical background, but to set it off and kind of give some infrastructure, if I could ask you, what is shared decision-making in a nutshell?
I mean, really, shared decision-making can affect our lives in many fields, but in the field of medicine, it's really kind of a more detailed, informed consent where both the doctor and the patient collaborate. And by collaborating, they come to a decision as to what is the best care for the patient, not what is the best care for the doctor. From the doctor's point of view, it really has become much more patient-oriented, and it should.
Mm-hmm.
So that's kind of a short but sweet definition. It could be the same thing between a parent and a kid, except of course the parent has more authority, but it's that interplay of listening and understanding the kid's needs, or the same thing with the doctor and patient, understanding the patient's need on an adult level and taking that and giving the patient different options.
Absolutely. And I think I even recall, throughout my own time when I was in medical school, I can recall a variety of situations where it was employed and where it wasn't. But without question, I think your analogy of kind of giving that platform to set up the conversation is very well stated, in that it gives the opportunity for a patient and provider to have that dialogue. So there's open communication rather than just instruction coming from the provider to the patient.
I'm kind of the Yoda in medicine and have been in practice for 40 years. And I'll tell you, when I started out, there was no doubt that it was a unilateral relationship. The doctor was somewhere up on a pedestal. The doctor says, this is what you do, this is how it's done, and that was it. It was rather, egotistical, dogmatic, and that has really evolved over the last couple of decades.
Yeah, and I think you're absolutely right. There's a concept of a pedestal where I think, in the old school, patients even had a sense of anxiety to ask any type of questions because, God forbid, they kind of speak up to that pedestal, right?
Right.
Yeah,
right.
Got it.
Thanks. And you know what? Doctors are human beings. We're fallible. Yeah. We don't always know what's best for our patients unless we ask, what's the matter? How does it affect you? These are important decision-making aspects, and I'm really glad that Solve has attacked that head on, because it's really an important concept.
Absolutely, yeah, and I think going back to what you said earlier is the physician only has a real snippet of time, right? Like it's a 10 to 15 minute consultation, and it's really hard to get a sense of what is going on in that patient's life and how the treatment mechanism impacts that patient's day to day.
Yes.
So I guess, we've touched on some of this in the first question, but really, I guess the next question I'd like to ask is, given the history and kind of the evolution of medicine, do you believe that there are individual events or collections of events that have occurred in healthcare or medicine as a whole that have created the need or kind of given rise to shared decision-making as an entity of its own?
Yes, I think there's several levels of this. Actually, an obvious level, which maybe people don't consider, is medical malpractice. I mean, when physicians get sued, many times it's because they didn't listen to the patient. Okay, they didn't listen to what the patient wanted. The patient remained conflicted because they didn't know exactly what route to take, and then they were dissatisfied when they took the route that they did. So that's one motivator. It's unfortunate, but that's
Yeah.
not the only motivator. I think the other is our culture has changed. We're paying attention to all walks of life like we never have before, and we should. And doctors have always been that way, you know, to a degree. I mean, I grew up with science fiction. I love it. I love Star Trek. Star Trek is it kind of got me used to saying, no matter what you look like, no matter who you are, no matter how short or tall, no matter if you have five eyes, it doesn't matter.
Yeah.
What really matters is listening to what you want and treating you with dignity and the respect that you deserve. So that's another cultural aspect that I think has evolved throughout the years. And finally, the third thing I think that's really been big is evidence-based medicine. As physicians, we have guidelines. We know what works. The problem is we don't necessarily know what will work for our patients because every patient has a different set of a different walk, a different path that they have traveled.
Mm-hmm.
And we have to understand that path in order to find out what's the best treatment for them. For instance, it may be that somebody wants to be DNR and they feel fine. They feel their health is reasonably well, but they're 95 years old and they say, look, don't resuscitate me. Even though we would say, well, you know what, you're in great health. And, people are living longer and who knows, you might live to be 105. So the point is, it's just, evidence-based medicine, cultural changes, malpractice motivations, and all of these things I think have contributed to saying, hey, let's listen to our patients, find out what's wrong, have a dialogue, and discuss the best options. Custom tailored to the patient.
Makes sense. And I think one of the things you had mentioned, Dr. Lipkis, in your statement was that at the end of the day, physicians are human beings, and there is, an opportunity unintentionally to create an error. And I think when you strip down the status and the title that comes with being a physician, often from a social context, we see that shared decision making has an impact not only on patients, but providers alike. The quality of the experience, the ability to communicate, and essentially what ends up unfolding as creating and investing more in a relationship between provider and patient, whether it's a GP and a patient or an oncologist and a patient. The shared decision making really has an impact on both parts of the equation. So in your opinion and from your experience, how do you see shared decision making and everything it stands for having an impact on both provider and patient alike?
Well, the impact is without a doubt positive. Imagine, like going into a situation and you're going to have a procedure done. And you're told, this is the way it's done. In fact, I'm going to give you a quick example of that with myself, okay, because I think it's relevant. Mm-hmm. I developed in 2016 a clot in my leg, and for some reason I decided to do a CAT scan looking for cancer. I don't know, it was intuitive perhaps. And I found a 1 centimeter renal cell carcinoma in my kidney. I went to a couple of physicians and they told me you've got to have half your kidney out, a heminephrectomy. I heard that and I said, well, are there any other options? Well, you could take out the whole kidney. I said, are there any other options? They said, no. I wasn't satisfied. So I looked and did for me as a physician, it's easier. I did a literature search. I found out that at the Cleveland Clinic that they were doing cryoablation. So essentially, there was a 30-minute procedure where they put a probe into my kidney and they froze it. And here I am 6 years later. So my point is, that was the equivalent of a colonoscopy for me.
Wow.
It wasn't shared decision making, but the decision making was limited by the physician. The couple physicians that I saw could only give me so many choices.
Mm-hmm.
And I had to go search on my own. But that can be alleviated because, at least in internal medicine, we can say, look, we're not satisfied with that one opinion. Let's get another one. And let's go to an expert around the world who has done these and knows most of the options. And you can do that in today's world. You can do that by the internet. You can do that by Solve.Care. It's easier by Solve because you've got the world at your feet. But so this is the kind of interaction that didn't necessarily occur with me, but I would have liked it because, number one, it saved a lot of money. I mean, if you want to look at costs, surgery on a guy who has to be anticoagulated, complications of surgery, et cetera, et cetera. So it saved on costs. It also made me feel good when it's kind of like, let's get the placebo effect going too. It made me feel good to know I could have a relatively simple procedure from, my vantage point, although the guy had only done 32 of them, but it worked out fine. And I didn't have to worry about all this anticoagulation nonsense and pulmonary emboli too from being laid up after an operation. So there, conflicts are resolved, costs are reduced. And this is actually shown in evidence-based medicine that shared decision-making actually does this.
True enough. And I thank you for sharing that story. I think, it's good in the end that you were able to access the treatment that was best suited for you and that actually gave the most positive impact on your quality of life. But I think from time and time again, from my own experience, when I was in medical school, I think that story would probably resonate with a lot of people, where they go to a physician and the physician gives them a limited number of options and they don't feel satisfied with really not necessarily the plethora or the excess of options, but really, even people without a medical knowledge must have a sense to know, well, there's got to be something more. There's got to be another option. And a lot of times physicians don't really necessarily have the understanding to give access to the plethora of options, or maybe even the time. Maybe they're just overwhelmed with the burden of work and they just can streamline it to, the 3 or 4 that are most conventional. So I think it's interesting that you shared that experience, and a lot of people would really probably have similar experiences in the past as well, which leads me to my next question is, given the spectrum of specialties that exist within medicine, do you feel that there are some specialties that adopt shared decision-making more than others, and some that can maybe have a better opportunity to adopt it more than other fields of medicine?
I think it all depends on your ego. The ego is the self-image. The ego is based upon, yourself. Our physician self-image is built up by helping patients and reading and learning. And if your ego is so large that you walk on water, you're going to be hard pressed to do a shared decision making. Mm-hmm. If you can flush your ego down the john, which I do every day, I think you're going to have a better chance at collaboration with your patient. For example, how easy is it for a surgeon to say, hey, look, you shouldn't have surgery done by me. You should go over here and actually just do watchful waiting and have an oncologist monitor you. It takes a lot. And you have to get by the ego to do that. Because it's, medicine isn't just about money. It isn't just about doing procedures. Again, it's about doing the right thing for your patient. So this really, it can be as simple as, you've got 2 medicines for hypertension, and which one should you choose? An ACE inhibitor, well, it might cause a cough. It might cause an anaphylactic reaction. A calcium channel blocker may not protect your kidneys the way that an ACE would. So I think you have to go through with the patient and balance those options out. So
Yeah.
that's relatively a simple collaboration versus, having a Whipple procedure maybe for pancreatic carcinoma
Mhm.
versus not having it. That's procedures probably lend themselves more towards shared decision making than anything else. So
Yeah.
I would say it extends across the field of medicine. It depends how receptive the doctor is. And there are many examples that involve procedures, but also, well, what about childbirth? How do you want to deliver your baby? Or what about death? Do you want to be in hospice, or do you want to do everything you can for yourself?
Yeah.
All of these things are examples of shared decision making, and they go across many medical fields.
Yeah. True enough. And I think you pointed out something very astute as well, is that especially in surgical fields, you see that as well, because the options can sometimes have such dire consequences. And I've seen that myself in medical school as well. When I was in orthopedic surgery, cardiovascular surgery, you saw a lot more conversations unfolding with the patient's family, bringing in a circle of care, where there were collateral members of the family that also were part of that conversation as well. And even in terms of social outcomes, I found that patients were more receptive to having an opportunity to sit down with the physician, for example, any support staff, and they'd have like a 1 hour conversation with the patient and their family approaching a very significant surgical choice. So it's definitely nice to see when you see it unfolding in person, and you can see the collective benefit both for provider and patient. And usually post-op as well, I would find that the surgeon who did the procedure would often have a better relationship. There'd be more of a platform for communication with the patient as well. And overall, in the context of the individual's healthcare journey, it just seemed to fit the bill more in terms of an appropriate modality of care.
I mean, I agree. If you want to bond with your patient, do SDM, shared decision making.
Yeah,
That's the easiest way to bond with them. The problem is, if you actually interview docs, probably about 65% of them don't want to do it.
yeah,
And I'm sorry, there's about a third that don't want to do it, but there's 2/3 of patients that want to do it. So
yeah,
probably most doctors are open to it and most patients are open to it. There's a few docs that aren't, and the reason for that is the time constraint.
yeah.
When you start going through, can I give you an example just
Please.
of, and this really gets into, shared decision making just doesn't involve the doctor or a set of doctors. It can involve a tool or a handout. So, one of the things that I got a lot was, hey, doc, my PSA is elevated. My prostate specific antigen, it's up. What do I do? So I actually would show them a tool, an evidence-based tool. And what it was is you took 1,000 patients and you did PSAs. 240 of them had a positive PSA. Half of those were false positives. So a lot of these people that had positive PSAs got unnecessary biopsies, which is a negative. Out of the 240 people that had elevated PSAs, 100 of them had prostate cancer on biopsy, so a little bit less than half. The other half had painful unnecessary biopsies. Now, out of the 100, 80 of them chose a radical prostatectomy. 20 of them chose, let's follow up and just wait. Out of the 80 that chose the prostatectomy, 60 of them had incontinence and erectile dysfunction. So that means that 3/4 of the people who chose prostatectomy had long-term issues.
Yeah.
So how many lives were saved out of the 1,000? One. Okay, maybe through a prostatectomy you saved one life. So I think, then that leads to the discussion, and it's time consuming. Should I do a PSA in the first place? Well, yeah, I want to find out if I've got prostate cancer early. But on the other hand, if it's only going to save one life and I have to go through this whole thing, biopsying and maybe an unnecessary biopsy, et cetera. Is it really worth it for me? So I can't give the answer to that. The answer really comes from the patient after you give all of the options. So there are tools like that that can be used, that patients can see and readily understand in order to make an informed decision.
Got it. And I think touching on the last thing you'd mentioned there is the answer really comes from the patient. And I think as people become a lot more exposed to different concepts within clinical care, it's up to the patient as well to advocate for shared decision making if they feel that is right for them. A lot of patients still want to go to the physician and be told what to do in a very black and white way, and that's their right if they'd like to do that. But as people become a lot more informed to different concepts, I think it's up to the patient to advocate and say, hey, doc, look, I learned about shared decision making. These are the entities that I'm looking at with you for my care. I'd like to engage in a shared decision making model with you moving forward. And I think those are the conversations that people are feeling a lot more confident to have with their providers as well.
I think an excellent point. And through my years, I've seen so many patients stick with doctors just out of loyalty.
Mm-hmm.
It's not a reason to stick with the doctor. You stick with the doctor if the doctor can help you.
True.
And it's within the range of medicine that you can be helped. And maybe you stick with them for bedside manner. I mean, a lot of patients do, but it's important that they get the full overview of the diseases, of the options, of the harms and the benefits. And that's more important than that bond of loyalty. Because I think the bond is actually strengthened by SDM, because then the patient feels, hey, it's a democratic system. I've got to say so here.
Yep.
And the doctor has enough knowledge to offer me the different options that can be utilized.
True. Absolutely. I agree with that. And I think you're right. A lot of people do stay with their physicians because of the sense of loyalty. But at the end of the day, it's the individual's healthcare. And if you're not receiving what you need from that relationship, there's no harm in looking for an alternate physician. But absolutely, I think as we progress in time, I've seen most definitely, even in my experience, a lot of patients are becoming a lot more confident, as they should, to ask for treatment mechanisms that fit their lifestyle. And shared decision making is definitely one that a lot of people have received very well.
We have to actually use more, the patient has to actually go into reasoning mode and get out of the emotional world. If you're in the emotional world, you say, oh, I love this doctor's bedside manner is so good. I'll do whatever he says or she says.
Yeah.
You've got to get out of the emotional world and say reasoning. What's the good? What's the bad with each option? And I think when patients get into that mode, it's easier. The problem is there are so many fearful patients that sometimes they don't know what to ask. And that's a good reason to bring a friend, somebody who can be more objective, so that if a patient is scared in the moment and can't reason, but is in the emotional arena, then that friend can come out and say, well, what about this? And what about that? And that's important, because sometimes when you're with a doctor as a patient, it's hard to think and reason because you're scared.
Yeah, true enough. And I think that the option of bringing a friend is something that, we never used to see before in healthcare. And well before my time, it was always doctor-patient one-on-one. But as healthcare evolves, we definitely see that landscape changing, where people have a greater comfort level to diversify the conversation and to add more texture to it, sometimes to offset maybe an imbalance where they feel they're unable to be objective with their provider and ask them those questions. And that brings me to my next question with respect to the future of healthcare. If you could please provide your comments on what you feel the future of healthcare would look like with respect to the incorporation of shared decision-making, and how it will shape the future of clinical care and population health as a whole.
Well, I think the future is here. I'll tell you what I like ideally. What I would like to see ideally is a Mayo Clinic setup. Okay, it's the only place in the country, I believe, where you can go to 4 or 5 different doctors and all of them are collaborating. The power of that is enormous. It's kind of like tumor board, where you get the pathologist and the cytologist and the oncologist Of course, that's done without the patient. That's the only problem with it. But
Yeah.
imagine if you could have a patient could have 3 doctors on at the same time, maybe a surgeon, an internist, and some specialist. And they all had a discussion with the patient about, here are your results. This is what I think is a good option based on these results. That happens at the Mayo Clinic. It doesn't happen at most other clinics. They're just kind of separate. It doesn't happen where I'm at because you refer a patient, you get a note back from the specialist, and unless you call all these specialists and get them on the phone at once, you're not going to have much dialogue. So I think the future is here because with a connector, like, and I'm probably getting into this a little bit early, but with a connector like Solve, you can get physicians on, a multiple physician input with the stroke of a pen. And I think that's really an important factor. And that's the future as I see it, where you can combine visual aids, doctor input, and all of these things to help your patient make a great decision. And, that's kind of what I see in the future. And it can happen, but I think you need the blockchain really.
Yeah, got it. Well, and that actually perfectly segues into my final question, and I think you've addressed some of it in your previous answer, was how, in your opinion, do you think shared decision-making incorporated and delivered by Solve.Care will impact healthcare delivery as a whole?
Well, the doctor can essentially write up a ticket, okay, for the patient.
Yeah.
I would like to have this visual aid, this article. I would also, for the patient to see. I would also like to have a couple doctors and around kind of a little mini roundtable discussion with the patient so that we can allow for a patient to make a better decision. So I think that can happen or will be able to happen shortly. Certainly with Solve, I'm used to a one-on-one, kind of discussion. But, the question is, can Solve.Care do that and have, 3 or 4 physicians provide input on a single consultation? And, once that happens, and I don't think that may be able to occur right now, or we're not far away from that. Once that happens, then you can have a physician put up this prostate tool that I already talked about. Well, here's all the different aspects. If you get a PSA, this is what can happen. And you can have another physician who's an internist talking about it. And you could have, if the patient's got prostate cancer, an oncologist come on and talk about it too. You can have all that input, everybody can bill for it, and all of that can occur at once. That's powerful. I mean, that's even more powerful than the Mayo Clinic, because with the Mayo Clinic, you get a report which has the input and the collaboration of all the physicians, but it's not with the patient necessarily. Mm-hmm. It's with each one of those physicians talking with the patient. Here, you could have the potential of several physicians with visual aids talking with the patient. That, to me, is powerful.
Makes sense. And I think that patient-centric approach is really, in my opinion, what's lacking. And as much as there are other institutions, other organizations that have a panel or a gamut of physicians looking at an issue, the absence of the patient is really kind of the issue. And I appreciate you shedding light on that, is that once we have the patient involved in that kind of working of communication, that really creates that powerful approach that really can revolutionize healthcare.
And the thing with Solve is, at least they are doctor-patient oriented. It's very doctor-centered in that they allow the doctor to do what they have to do to get their patient well. Mm-hmm. And part of that is shared decision-making. And, there's a lot of telehealth companies, and I've actually in the past before Solve, I actually interviewed with a few of them just to see what they were like. And they would say, well, your visit can't go over 10 minutes. I said, 10 minutes? I said, I don't even get through my hello in 10 minutes. I said, much less a disease and the patient's understanding and the harms and the benefits of that disease. So I think it's important that you have a telehealth company that doesn't restrict time. Yes, it might be a little more expensive, but it's worth its weight in gold because you get that dialogue, that interplay that patients long for with their doctor. I hear so many times, well, yeah, I went in to see my orthopedic doctor and he spent about 5 minutes with me and then left.
Yeah.
You can't get anything done. There are doctors in the ER who will take a history but won't examine you or go through your lab results because they're so rushed. I understand that, but what I like about Solve, it can slow the process down, the interaction, and that's a good thing because the interaction can be meaningful as opposed to, oh, you're limited to 10 minutes or you're limited to 15 minutes or you won't get paid after 17 minutes of conversation.
Yeah.
So I think that that's actually a good thing. And, I think it's also the concept, when Galileo said, hey, look, the earth isn't the center of the universe, and everybody was up in arms. He was right. The sun is the center of our universe. Essentially, the patient is the center of the doctor's universe. And that's how we need to treat the patient today. And they need to be put up on the pedestal, the opposite of what we really started with.
Fair enough. And I think I'll probably summarize, I think, what you said, and there's probably a mutual agreement here. And you'll excuse me if it's not verbatim, but there was an old quote from Benjamin Franklin that always resonates with me, and it stood with me throughout my medical school. And it went along the lines of something to the equivalent of, show me and I'll forget, teach me and I'll learn, engage me and I will evolve. Something along the lines of that. And that always sticks with me with shared decision making, is it's right on point, is that once you bring someone into a level of engagement, they have the opportunity to grow from there.
I don't think Sir William Osler, the father of clinical medicine, could surpass that phrase. But the one thing that I've always gone by is what he said. There are two things. Listen to thy patient and you'll get the diagnosis.
Yeah.
And then the second thing he said is that the good doctor knows the disease. The great doctor knows the patient with the disease. And that's shared decision making. He knew it before we did.
True enough. True enough. It's a very astute statement in just a short amount of words, but it summarizes it perfectly. Dr. Lipkis, I cannot thank you enough for your time today. We have run through the list of questions. As usual, your contributions, your insight are very much appreciated. I'm sure we'll have a lot more to talk about in the near future. I'm sure this is just the beginning of our track discussing shared decision making. To our audience, to our members who've listened in, thank you for your time. And Dr. Lipkis, again, appreciate it as usual and hope to talk to you soon.
Thank you so much. I always enjoy these kind of roundtable discussions. Appreciate it.
Always a pleasure. Talk to you soon, Dr. Lipkis.
So long.
Take care.